All right, in this lecture, we're going to talk about coronary artery disease and acute coronary syndrome. So, acute coronary syndrome will umbrella our STEMIs and NSTEMIs and unstable angina. So, things that we think about as we are taking care of our clients, typically in the hospital setting, it's probably hard to find a client that has like a new diagnosis of chronic stable angina unless it involved actual damage to actually bring them into the hospital. So just like hypertension, CAD can be insidious. We do know that there is a process called atherosclerosis. It's the major cause of coronary artery disease. It involves the development of deposits of cholesterol and fatty lipids. In this particular instance, primarily within an artery. That could be your coronary arteries, that could be your pulmonary vasculature, your cranial vasculature, because we know that once we have plaque one place, we typically have it every place. What's going to happen is that this is going to be a condition where oxygen supply and nutrients become narrowed or almost blocked due to the atherosclerosis and potentially to the arterial sclerosis. As plaque builds up, the blood flow will decrease. This leads to ischemia. We're going to refer to that angina. We're going to refer to that ischemia as angina, so chest pain. That's typically when the O2 demand exceeds supply. And then, of course, we're always at increased risk for that plaque rupturing, which would include the formation of a clot, thrombus, could potentially lead to a myocardial infarction, PE, a stroke. So while we may not see it until it is progressed, it's our job to do a lot of patient education once they do come in and start having this diagnosis. Okay, so again, we're going to look at the classification. Stable ischemic heart disease is chronic stable angina. You're going to see it listed kind of both ways. And then the umbrella terms for ACS, which is the acute, and you guys know that an ST elevated MI is acute, an NSTEMI is acute, an unstable angina is acute. So we are going to have issues if we don't do the things that we're supposed to do as a client, and if we don't do the teaching that we're supposed to do as a nurse. So in this illustration, kind of to the right, you can kind of see the coronary arteries. I do want to point out the left descending coronary artery. So that is going to be what we refer to, or what you may have heard of, referred to as the widowmaker of the heart. So if you do have blood flow issues, there is a high likelihood that that's where we're going to find that accumulation of plaque. That being said, if you have plaque one place, you have plaque every place, and that includes every other coronary artery. So the progression, the patho is pretty straightforward. You have your coronary arteries. We have some changes either into the structure or the function of the heart. We have bad lifestyle choices, bad modifiable risk factors. We develop plaque. That plaque leads to occlusion. That occlusion leads to ischemia, which we're going to call angina. And then if left untreated, that chest pain, that angina, is going to turn into a myocardial infarction. All right, so things to look for, typically this is can be a normal part of the aging process, especially in clients who become physically inactive. If you have long-standing histories of hypertension, if you have risk factors for heart failure, which will include diabetes. I'll even throw in COPD in there because it's this big circular presentation of that all of these disease processes affect one another. So you could say hypertension, heart failure, diabetes, COPD, kidney injury. Lots of information about lifestyle habits, especially smoking and diet. They are probably the biggest contributors to the development of coronary artery disease or to the development of atherosclerosis. And then sometimes it's just, luck of the draw. I have poor genetics. I have a predisposition to issues with the accumulation of plaque, which are going to affect perfusion and the ability of the heart to deliver oxygen. A couple of things we're going to look at. We're going to look at the cholesterol, the LDL, the triglycerides, and the HDL. Cholesterol is, we want that number less than 200. Our lousy cholesterol, we want that less than 130. Our triglycerides, it's going to be a range of information, so it's just 35 to 160, somewhere in there, and then you just divide it up, knowing that the higher number is for males, the lower number is for females. And then our good cholesterol, we want that. And notice it's the only one kind of here that says it's greater than, right? So our happy, we want a lot of. You want great happiness and not lousy cholesterol. So a couple ways to remember it. Risk factors: age, gender, ethnicity, family history, genetic predisposition. We can't change those things. What I can do is a lot of patient teaching on IDoCash. We can monitor their I's and O's, making sure that intake is equal to or greater than output, so we're not retaining fluid, which is going to be another risk factor for the development of like heart failure. Talk to them about their diabetes if they have that diagnosis, about their lifestyle. We'll get their information for their cholesterol, and that maybe have them come back once we've changed all of these modifiable risk factors to continually evaluate that information. Again, just age, smoking is always bad, and histories of hypertension. So unfortunately, some of the information we do know about coronary artery disease and its progression is that women who smoke are more likely 19 years earlier to have issues with chest pain than non-smoking women. If it's diabetes, it's 2 to 3 times more likely. We know that diabetes is a huge risk factor for CAD, and diabetes affects more women than men. And then we also are aware of the age-adjusted rate of heart disease for African American females is 72% higher than their Caucasian counterparts. So a lot of this can be related back to either poor care, poor access to care, poor economic or socioeconomic factors. But unfortunately, our women will also not have, or may not have, it would be a better way to describe it, a typical presentation of chest pain. It may just be feelings of malaise, feeling of being tired, short of breath all the time. I have indigestion. So with our health promotion and disease prevention, again, we're going to talk a lot about exercise, having regular checkups, about diet, especially low saturated fats and sodium, or promoting smoking cessation. Those are common health promotion and disease prevention categories for CAD. Diagnostic-wise, I do see just a few things that we can look at as ST depression. It could indicate ischemia. Triglycerides, obviously, that's going to give us information as well as our cholesterol. Our CRPs and our ESRs are, again, they're going to tell me that I have inflammation, but it's not going to tell me where that inflammation is. To get the opportunity to evaluate ST depression or to get a 12 lead, they're probably going to have to come in complaining of some sort of discomfort. And what we're going to look for, again, are those changes for ischemia or infarction. So is it a new Q wave? Is it ST depression? Or is it, worst case scenario, ST elevation to say that they're having a true myocardial infarction? You would still expect, if they came in presented that way with some chest pain, that we're going to draw some troponins. Their lipid panel, probably get an echo because they are at increased risk for heart failure. And then we can also maybe expect them to go down to the cath lab. We want to visualize those coronary arteries and maybe perform some interventions such as stenting or angioplasty. If it's a clot, we can also do an embolectomy. It just depends. These are typically the hospital tests. Again, but most of our clients that get a diagnosis of CAD, they're not getting that diagnosis in the hospital. It's probably through their primary care providers. We're going to look at information about, about are they compliant with their aspirin regimen. So our antiplatelets are going to include aspirin, and we're going to add in clopidogrel. We'll talk more about that when we talk about STEMIs and NSTEMIs. I can give both. They work differently on the clotting cascade. They work differently on the platelets. So they're given basically to prevent that clot formation. If you have that area of injury in your coronary arteries, it's going to attract your platelets. The aspirin will make them not stick, and basically the clopidogrel will make them bounce off the injured area. Our ACE inhibitors or our ARBs, it depends. If they have a bad reaction to an ACE, we can give them an ARB. We're going to do that to help prevent that remodeling. So we talked about the changes in the structure and the function of the heart. ACE inhibitors help prevent those changes. And one of the ways that they do that is to decrease afterload, or i.e. have an effect on the blood pressure. Statins, we can do atorvastatin, simvastatin. Those are going to help us with lower our lousy cholesterol. The nitrates we're going to look at to improve coronary artery blood flow. Nitro, we have said in the past that it will decrease preload and afterload, so you got to look, are there any underlying comorbidities like an aortic stenosis that would make me worried for that? But generally speaking, a lot of, just PRN, sublingual nitro tabs with our patient teaching about taking it once every 5 minutes up to 3 times. If the pain doesn't go away in the first 5 minutes, to go ahead and call EMS. Diuretics, if we're concerned about a volume issue, beta blockers can be given to help decrease afterload but also reduce the heart rate. And again, beta blockers have that nice little property where they let the heart do the same amount of work with less oxygen. And since this is an issue with ischemia, that's a great thing for us. So make sure, we're looking at their histories. We're assessing their pain. We're going to talk about how we're going to differentiate just stable and unstable angina. Make sure that you're thinking about getting those lab results in and evaluating those things, and just lots and lots of patient teaching. So chronic stable angina is important because what we want to think about is now I'm having an actual physical manifestation. It's not these vague symptoms. The client is having chest pain. And one of the most obvious things that I think when we talk about chest pain usually gets dropped off by our students. If I have a client complaining of chest pain, I want to ask them the follow-up information. It's not just my chest pain is 10 out of 10. Okay, think about what makes it worse, what makes it better. So provokes it. What is the quality? Does it radiate? Is the pain severe on a scale of 1 to 10? Very important if I'm evaluating an intervention, because if the pain does not go away with the administration of morphine, if it is a true MI, then that's a big problem. Whatever I did was not effective. And then the O here, they've kind of combined their O with their T. When did the discomfort start and how long has it been going? Is it constant? Is it intermittent? Whatever we're trying to elicit from that client, whatever information. So with angina, right, we typically think of chronic stable angina as something that is predictable. It usually occurs because I'm doing something, and it's probably something that your nurse or your primary health care provider has told you shouldn't be doing. So lots of just patient teaching. Hey, it happens when I'm doing something. I want you to sit down. I want you to try to catch your breath. If it feels like it's chest pain, then we can take the nitro. But generally speaking, this pain, this type of angina should go away with rest or meds. Whereas unstable is a pre-infarction, starts occurring at rest and starts occurring more frequently. Pain, chest pain or leg pain or whatever, it does not matter. It should not wake us up in the middle of the night. If it's doing that and we're talking about chest pain, it's a warning sign that we need acute intervention. Unstable will include STEMI and NSTEMI. Then we have this other type over here, this Prinzmental's or variant angina. This is from coronary artery vasospasms. So you can see pain at rest, but it's reversible, and that's the thing to think about. Usually it's intermittent, so you may have intermittent ST elevation. And we'll look at that as well when we talk about variant angina. Silent ischemia. So we've talked about coronary artery disease, and we talked about those compensatory mechanisms. You need to understand acute versus chronic. All right, so silent ischemia, they may not have typical presentations of chest pain, but once I do make the determination to get a 12 lead, what I could see are ST elevation. So this is obviously ST elevation, right? It's huge, it's big. The S does not come back down to that isometric line or below it. So this is very acute. This is probably the person who is going to get sent to the cath lab. Less worrisome, I want to say, is changes to the ST segment or to the T wave themselves. So here I have ST segment depression. All right, so that S does come all the way down and that ST segment is below the isometric line, but you do come back up and have a T wave. Whereas with this one, I have PQRS, you see ST depression here, and now you have T wave inversion. Both of those things are not particularly useful in diagnosing angina unless it's a relatively healthy client. If the client has a cardiac history, then having changes to the ST segment as far as depression or inversion of the T wave are par for the course. It's good if this was not their baseline. Or excuse me, it's good if this was their baseline. If this was not their baseline, then it's an acute change. So again, most of our clients are going to be asymptomatic. We need that 12 lead as well as our troponins and all our other labs, to make a definitive decision on our plan of care for those clients. And again, we've talked about the fact that it's the circular process with these other comorbidities. So with chronic stable angina, some of the things that I expect. Well, I expect chest pain, but that chest pain should go away with rest or medication. So it can radiate, we can talk about the substernal chest pain. We can talk about the shoulder, the arm, or the jaw pain. What you need to understand is that pain in these areas is not normal and that we need to investigate reasons, and that's why we do all the diagnostic tests. Typically, it can be described as crushing. Usually occurs with exertion or stress, so physical or emotional, but is relieved by rest and nitro. We expect you to be tachycardic. You may feel heart palpitations. You just may feel generally unwell because that lack of oxygen is going to cause those tachyarrhythmias. In which case, because you're not getting enough oxygen, you're going to start breathing faster and you're going to be more labored. Usually, the pain lasts 3 to 5 minutes. So I do see some changes in my ST segment for this client that came in. They're complaining of chest pain. And I have P, QRS, and then I see this ST segment depression. That's not back to that isometric line. That's telling me of ischemia. Here we do see the typical presentation of pain radiation when we're talking about MIs. What we need to ask ourselves is, do we have a baseline? Is this acute or is this chronic? ST depression can be chronic. Chronic stable angina literally says chronic. So we've talked about typical and atypical. So women and elderly may not present with typical signs and symptoms of angina. What I want us to think about are our perfusion, our respiratory words. Changes in LOC, you're dizzy, can't quite catch your breath, you have fatigue, you can have pain in the abdomen or the back. If you have nausea, you are starting to think more along the lines of a true MI versus chronic stable angina. Same with sweating. Changes in your skin temperature and color, and then feelings of indigestion. Those are atypical presentations. They could have no presentations other than just basically feeling unwell, and they come into their doctors and they get a 12 lead, and we see changes in that ST segment. Prinzmetal's is technically classified as a chronic stable angina. Again, this does occur at rest, but it's usually in response to a spasm of a major artery. Usually we're thinking clients who have a history of either migraine headaches or Raynaud's phenomenon. Both of those are related to the vasculature. You can have spasms that occur in the absence of coronary artery disease, and it may present as transient ST elevation, which when we do see it can be associated with complaints of chest pain. So all transient ST segment elevation means is that every second QRS complex, every third, every fifth, it just depends. Those segments have changes that are associated with ST elevation. So here we see kind of the normal versus the ST segment depression. And again, I just need to ask myself, is this new or is this old? Is it acute or is it chronic? Once we start thinking more along the lines of, okay, I've got issues in the coronary artery disease, maybe it's a history of CAD and hypertension and diabetes, and I get diagnosed with chronic stable angina, we're going to try to elicit more information. So just your normal stuff, your health history, your physical exam, listening to heart sounds, looking at your lab results, making sure that you're getting a 12 lead for any new or recurrent changes, usually chest pain. Chest x-ray to help identify cardiomegaly or any fluid in the alveoli. An echo because they are at risk for heart failure, as well as an exercise stress test because remember, we're trying to elicit those changes in the ST segment to tell us, to verify that yes, we think that you have this, and that is telling us that what we think is true. Chronic stable angina, just lots of teaching. I want you to be pain-free. Again, if the pain does not go away, then your intervention wasn't effective. We want to preserve the myocardium as much as possible with our use of medications. We want to provide immediate treatment, teaching with changes in their lifestyle, teaching them how to cope with this new diagnosis of chronic stable angina. We want to still see that they're seeing a cardiologist and that are participating in a rehabilitation plan. And then, of course, how to modify those modifiable risk factors. So if you or someone you are with has chest pain that lasts more than 5 minutes, do not wait to call 911. You're going to call 911 after that first nitro tab. Typically, if the first nitro tab did not work, that second or third one probably aren't going to work as well. So what I want us to think about is, I am out here, I am taking a sublingual nitro tab or a sublingual spray. We're going to say later on that the only thing that gets rid of the pain with a true MI is going to be our narcotics. So for us, that's going to be morphine. This client can't wait because that time frame is hugely important. If I expect the pain to go away because this is a stable angina, and it does not, we are starting to trend more towards the MI, and it's better safe than sorry. Worst case scenario is they get there and you've taken 2 and the pain is completely subsided. EMS is still probably going to tell you that you need to go and either check into the hospital or make an appointment with your primary healthcare provider. We want to teach them to chew aspirin. So over the phone, typically we could say 81 milligrams or 325 milligrams because most people who carry around, unless they know they have chronic stable angina, they're not carrying around a baby aspirin. But again, we want to have that immediate effect on the platelets so that they don't clump together. We know that aspirin is especially effective if taken in the first 30 minutes. If you have other changes that it's more than just chest pain, be careful with aspirin because if it's a hemorrhagic stroke, you could have bad outcomes. And again, even if your symptoms stop completely in the first 5 minutes, you still want to make an appointment for a follow-up visit. So this is an exemplar. This is exactly what you would see on an exam. Hey, which diagnostic test do I expect? I need an ECG. I need to look at my ST segments, and I need to look for T-wave inversion. I need a troponin, whether it's I or T, or even if we're trending the delta now, which just means you're taking the troponins earlier than we would have normally, and then you're comparing one value to the next set of value. Long term, we're kind of thinking a stress test because we want confirmation. And again, this could be either chemical, usually that is the adenosine, or the exercise stress test. And we talked about that in our diagnostics PowerPoint. What I expect immediately for chest pain in the hospital is Mona, and not in this order, right? So you want to give supplemental oxygen, you want to give morphine, nitro, and aspirin. All right. So Mona is in the hospital. Morphine is going to decrease preload and afterload. It's the only thing that's going to eliminate the pain if it is a true MI. Supplemental oxygen, the whole issue is ischemia, so supplemental oxygen is always recommended. Nitroglycerin, up to 3 times for the sublingual, right? So we need to ask them and get good reports from our EMS crews, as well as making sure that they've taken their aspirin. That is generally it. So when we think chronic stable angina, when we think variant angina, we want to think about things that are responsive to our treatment plans. If it is not responsive, then we've moved more into the ACS, which is going to be our STEMIs and our NSTEMIs. So here on this illustration, that you can clearly see that if I just looked here, this looks perfectly normal. Whereas in this one, I see clear ST elevation here, here, and even there. Comparing and contrasting. So chronic stable angina, we said usually it's that time frame, 3 nitros every 5 minutes, that's 15 minutes. It's going to be precipitated by exertion or stress. The pain is going to be relieved by rest or nitro, and it is not associated with nausea, epigastric distress, dyspnea, anxiety, or diaphoresis. Pain with an infarction will typically last 20 to 30 minutes, if not longer, without cause, usually often in the morning. So think about all the stories that we hear. We have these young, fit people, they're going out and they're running, and then they die from sudden cardiac death. It could be related. They could have had an MI, and because they were out running in the morning, they didn't have the tools necessary to help recover those clients. The pain is only relieved with morphine. And we do associate this with nausea, epigastric distress, dyspnea, anxiety, diaphoresis, and fever. Here, we do see that I have ST elevation in this tracing. I see PEQRST. I wish their heart rate would be 69. It depends on, the amount of ischemia and the other comorbidities, but it's a good illustration of ST elevation. So again, on the left, we see how that process of kind of plaque happens and how it decreases oxygenated blood flow. Signs and symptoms are still sudden crushing, radiating chest pain that continues despite, and that's the key word, despite rest and medication. All the signs and symptoms we talked about as far as shortness of breath or pain radiating to the back, to the left arm, complaints of heartburn, diaphoresis. And again, we talked about the typical and atypical manifestations of chest pain with our female clients. So we want to check our pulse. So if you have persistent chest pain, again, usually greater than 20 minutes, complaints of upset stomach, lightheadedness, shortness of breath, diaphoresis. So PULSE. That's checking our pulse for myocardial infarction. Again, we're going to start this process as a CAB if we're just finding them unresponsive. CAB is what we talked about when we talked about VFib, VTach. So think about it. Most people who die from an MI, they don't die because of the ischemia. They die because of the dysrhythmia, which is technically still ischemia. So you're still going to go through the process. Hey, you're okay. Check for pulse, check for breathing. You're going to do those two things at the same time, and then you're going to initiate CPR, and then go through that process of making sure that you're checking the airways and giving breaths in the hospital. So, emergency care of our client with chest pain, sit them upright. Give supplemental oxygen. Try to get those sats to 95. Don't chase the ghost. If you can't get them, but they're above 90, you're probably okay. Obtain a 12 lead. It needs to be read within 10 minutes by the MD. If sublingual nitro and aspirin have not already been done, we can do those things, but again, that's where you're going to have to get good information from both the client or the client's family and from your EMS crew. Make sure that you have established at least 2 large bore IV routes. It's very simple for this. We may need to end up giving IV push medications as well as continuous infusions of other medications. We've talked about pain, so morphine. And then we talked about our troponins. And for us, we said a troponin should be 0. If it is not 0, we have issues with ischemia. So at any point, if anyone from myself to National Council of State Boards of Nursing, and you see information about troponins or ST elevation, make sure that you're answering it in a way that's going to reflect that that client is having ischemia. So again, we go back to our treatments. So immediate, we talked about MONA. Later on, we're going to add a MONA B to this, but that's B is probably at discharge, and you can probably guess that that's our beta blocker. For STEMIs, it is more likely that they are going towards either the cath lab or to a thrombolytic. So alteplase, streptokinase, TNK, TPA, right? So medications if it's related to a clot. Again, we can get that information from probably an echo. If they have a long-standing history of AFib or something like that, that's kind of telling us. We could also do potential surgeries. So a PCI is a percutaneous coronary intervention. Used to be called pizza back in the day. We can do a coronary artery bypass graft or an endarterectomy to go in and basically cut out that blockage. We know that anytime you give a thrombolytic, watch for signs and symptoms of bleeding. So once we've done those emergency interventions, we're going to think about our long-term plan of care, prevention, and rest. So if we think that IV heparin in this particular case would be beneficial, we can certainly do a continuous infusion of heparin. And then here we see just having nitro prescribed as a PRN medication. There's our beta blocker. And you can also consider a calcium channel blocker. So nicardipine, nifedipine will help more with the coronary arteries. Or if you have a dysrhythmia, you can certainly consider diltiazem. So again, just kind of how we think about it, morphine, oxygen, nitrogen, aspirin. You see we've now included the ACE as part of the aspirin. Again, the ACE inhibitor is going to help prevent remodeling. And then a beta blocker, an IV beta blocker initially if we have issues with tachyarrhythmias. Sedatives, thrombolytics, anticoagulants, rest, cluster care. And then, of course, stool softeners so that they don't have issues, maybe viggling down, putting undue stress and exertion on their body while they're having issues with myocardial infarction. Biggest complication is dysrhythmias. We see that up there in the corner, that client has gone into ventricular tachycardia. Issues with potential for shock. So initially you may see an increased heart rate and then increased blood pressure. And then as those compensatory mechanisms begin to fail, you're going to have drops in your blood pressure and drops in cardiac output. Changes in skin color and temperature, the accumulation of fluid in the lungs because now you have a bad pump, JVD, changes in LOC, 20% of your cardiac output when it leaves the ventricles goes to the brain. If you have drops in that 20%, you can see that you're going to have changes in LOC. In the ED, it needs to be fast. So we need to get that 12 lead. It's usually you're sitting out there, they're going to come back, they're going to grab you, probably to start an IV and obtain a 12 lead to make sure that if we have to do emergency measures that we can. We've talked about the fact that most people die because of the dysrhythmia and not the actual MI. So having a 12 lead and having the client on continuous telemetry is going to be beneficial. We want to restore perfusion as quickly as possible, but we do still have time rules, just like we had for stroke. So it has to be 6 hours from a witnessed MI for the inclusion of thrombolytics. And then from the time that they get in our door to the time that they get that thrombolytic, it has to be 30 minutes. So a very tight window. So you get 10 minutes and 30 minutes. And then in that next 60 minutes, we want to get them stable or as stable as possible and send them to the cath lab for either their PCI or their balloon intervention or their stent. Changes that we're going to look for. Again, this is repetitive. We've talked about this already, so bear with us. I have a normal ST segment in 1. In 2, I see definitive ST elevation, right? That's a STEMI. ST elevated myocardial infarction. This could still potentially be an NSTEMI, which basically means instead of them going to the cath lab in 90 minutes, we may choose them, as long as they're hemodynamically stable, to send them to the floor. Usually it'll be the step down or the ICU. It depends on the severity of the signs and symptoms. And treat them there, and then maybe the next day get them scheduled for the cath lab or the exercise stress test or whatever it may be. But here you notice it can be harder to see this ST depression. Not so hard to miss that T-wave inversion. The only time I care, again, is if this or this are new. You're not going to know if it's new unless you have a baseline 12 lead or a history of that client's other cardiac comorbidities. So again, I expect them to go to the cath lab. I expect them to go to the cath lab maybe the next day or a couple days down the road, as long as they're hemodynamically stable. So here we have a mix of bad things. So, and I particularly like this one because it is a good example of I have multiple comorbidities happening. So right now I see that I have a P wave that's by itself. But when I do have a PRI, it is consistent. All right, and we talked about if you have more P's than QRS's, and you have a PRI that is consistent when there, it is a second degree type 2. So I do see lots of dropped QRS's, but inside those QRS's, I for sure have some ST elevation. This is typically what we would expect to see from our troponins. A troponin should be 0 for us. What we would expect is if we look at the levels, We see the red line is the troponin, and we do see that you have the CK, CKMB, myoglobin there as well. But we expect this bell curve to happen, and you see how quickly we expect those troponins to rise. This is the first 6 hours of the myocardial infarction, and you can see that that is where you are going to start doing the most amount of damage, and then it's going to start that healing process because now it's starting to trend back down. It's not going to trend back down if you don't get that client hemodynamically stable. And that's why we draw our troponins as part of a process of multiple troponins. And now with the inclusion of the deltas, we are actually drawing those labs even sooner than before. But again, troponin I, troponin T, generally what's going to happen is that those levels are going to start to fall off, but you're still going to have that area in the heart that has been damaged, so you're going to have a less effective pump and you're still going to be at increased risk for heart failure. You will see on some of your practice questions there is information regarding myoglobin. Myoglobin is related to muscle. Unfortunately, it's not cardiac specific. It's okay to know, but this is not something that we regularly draw outside of an ED potentially, or maybe an ICU if it's an ongoing issue with a myocardial infarction. It's the same way with the CK, CKMB. Again, those are markers that are telling me about stress or about injury, but they're not specific to the heart. And we've already, well, actually, sorry, we haven't gotten to heart failure yet, but when you do get to heart failure, we'll talk about why we want a pro-BNP or BNP. It's not for the MI itself, but because that client is at increased risk for developing heart failure, or the heart failure is the reason for the chest pain. So it's as a true myocardial ischemia versus demand ischemia that's causing that chest pain. We're going to do frequent vital signs, right? You're just going to follow your institution's policy. But the reason you're doing it like every 5 minutes, as you can imagine, is you're giving nitroglycerin every 5 minutes. We want them to be hemodynamically stable. We want to make sure that there are no complications and we're not trending down. Again, serial ECGs. So again, that will help us evaluate the effectiveness of our therapy. But more so, you're probably going to be looking at telemetry monitoring, and then we'll perform those serial ECGs as we have changes, either to what the client is stating for pain or to what the actual monitor itself is showing me. We've talked about OPQRST, so good follow-up questions. And then yet again, we've talked about it extensively that kidneys are vital to what the heart does, and the heart is vital to what the kidneys do. So we want to see our hourly urine outputs, at least initially, and in the ICU, and you want that to be greater than 30 milliliters an hour. So all in all, just make sure that we're looking at our cardiac enzymes, big one's troponin, our electrolytes. You can have issues with potassium, calcium, magnesium. I expect to have ABGs drawn, probably a lactic acid at this level. We expect to give them supplemental oxygen to maintain IV access, and then of course to promote energy conservation. We want to cluster our nursing care. Our primary goal for reperfusion procedures, so PCIs or in worst case scenarios CABGs, is to restore perfusion. I'll give you some images of what that kind of looks like. We've talked about thrombolytic therapy, right? So 6 hours of a witnessed MI. We want to see that ST segment return to baseline. If not, we may have to send them to the cath lab for thrombolysis. If it fails. And obviously, anytime we're using those clot busters, the big complication is bleeding. I expect them to have a stress test at some point. We want to use that stress test to try to elicit those changes. However, if they're starting to develop those changes, it's also telling us that we need to stop that test. So what do we know about those clients that are going down for cardiac catheterization? Right, this cardiac cath is for clients who are experiencing acute chest pain / myocardial infarction. Usually it's a STEMI. It's going to be up to your healthcare provider and what's going on with your cath lab. We know it's invasive. We're sticking a catheter in through your body and threading it to the right side of your heart, and then through your pulmonary vasculature and into your left side of your heart. And then we're going to be looking to inject dye so that we can see what's going on. We can see the areas of occlusion. And then they may do some balloon or balloon stenting. It just depends. If they don't stent it, the outcome is that we would push the plaque back up into the coronary artery walls. So basically we're smushing it around, giving it a bigger lumen to open in. And with the stent, we're actually using a drug-eluting stent to ensure that that coronary artery stays open. And with those drug-eluting stents, that's would be more typical for the clients who need dual therapy as far as the aspirin and the clopidogrel. We know that that catheter is going to allow for a visualization of the coronary arteries. Again, we may use contrast media, so we need to check for allergies. We need to check for kidney function. We do want to frequently assess for bleeding at the insertion site once they're coming back up to us on the unit, whether that be femoral or radial. Usually they're going to have a dressing or a TR band on there to help prevent bleeding. But the expected outcome for the cath lab, if I send you down for chest pain, is no chest pain. If they come back and they are still having chest pain, which is possible, because just like with those reperfusion dysrhythmias, we can have issues where the actual coronary artery becomes totally occluded even after intervention. So just have to monitor them carefully. Make sure you're checking for distal pulses. If you lose a pulse at the insertion site, we've probably created a blood clot. So we'll have to perform further interventions. And then make sure if it's an active bleed, you're going to put pressure either at or above the insertion site. So here is kind of what we're talking about. So we did some PCI, so coronary artery angioplasty, cath lab, PCI. All of that is basically telling us that we're doing something invasive. And so here I do see that I have issues with circulation. I have a narrowed lumen here in my coronary artery. I do believe that this is the left descending coronary artery, because I think pretty sure this is the circumflex. And you see now whatever procedure which we did, whether it was a stenting, whether it was an embolectomy, whatever that PCI was, I have increased blood flow. So again, my outcome should be no chest pain and then no dysrhythmias because of that reperfusion risk. So here's what we see with the PCI. Again, this is an invasive procedure. You see we're inflating the balloon, and the balloon is pumping up a stent that will stay in place to allow for blood flow. Post-procedure, again, this is stuff that we've covered in our diagnostic tests, PowerPoint and video. They're going to be on bed rest for a prescribed amount of time. Usually it's an hour to a couple of hours. We want to teach them to have that insertion site immobilized, especially if it's a lower extremity. Monitor your vital signs frequently. Monitor your distal pulses. We may need to do anticoagulation medication later on. Usually that's going to wait 24 to 48 hours if we did like a TPA or something. We would expect long-term nitrates. Again, we're going to use the nicardipine, nifedipine to promote coronary artery vasodilation. Nitrates, again, we could consider isosorbide mononitrate, dinitrate, or do lots of patient teaching about the sublingual nitroglycerin, aspirin and clopidogrel therapy, and about the increased risk for bleeding, beta blockers, ACE inhibitors, and more importantly, assess for complications. So kind of here is our little laundry list of things that I want you to know for MI. Nitrates, they're vasodilators. They decrease ischemia, thereby decreasing pain only in stable angina. If it's unstable angina, the pain will only be relieved with morphine. We do know that those nitrates are usually administered sublingually. We're going to do patient education here in a second about making sure that they have it on them at all times, etc. Calcium channel blockers, or CCBs, are again to help relax the blood vessels, increase oxygen supply through dilation of the coronary arteries, and that will decrease the workload of the heart, which is something that we want. Again, beta blockers are typically for the same reason. They decrease myocardial O2 consumption, they decrease preload, they decrease your heart rate. Beta blockers, depending on the course, are usually added on to whatever regimen that you have at discharge, unless you are already on one, and then we just may make adjustments as needed. Antiplatelets, anticoagulants. We're talking antiplatelets, aspirin and clopidogrel. Our anticoagulants, we could expect them either with a direct oral anticoagulant or warfarin. Again, the big risk for that is bleeding, so do lots of patient teaching. So here is our anti-anginals. Again, our nitrates, nitroglycerin. This is used at the first indication of chest pain. And again, we see that we do have our isosorbide mononitrate or dinitrate. Mono is PO, dinitrate is sublingual. And that's going to be more of a, not a PRN medication, but more of a scheduled medication. Patient teaching. So the first thing I see is I have my little brown container over here. I'm going to keep it stored in a cool, dark place away from light and heat sources. So don't put it in your pockets, even though it's saying have some on you at all time. Obviously, your body heat could make it inactive. You should always keep someone on hand. Wear your medical ID bracelets. If you do have chest pain, we want to teach them to stop the activity and to rest. And again, it's going to be every 5 minutes. Make sure that you're calling 911 if it didn't work after the first dose. And then once it's open, they need to be replaced every 6 months. We can use transdermal nitrates. Usually that's going to be for somebody more along the lines that have an issue with blood pressure, and the blood pressure may be leading to the ischemia. You know, these nitrates are going to be administered. You're going to have to open a package and squirt it basically on a piece of paper that tells you if it's a 1/2 inch or 1 inch or a bigger dose. And we would still be giving it for the same reasons. It's just a different form of prophylaxis. With the transdermal, what you want to be careful of is that you're not leaving it on there for 24 hours, that you are rotating sites, and then before you put the new one on, you're cleaning the old site with soap and water. Don't rub it in, you just place it on their skin. Don't touch it with your bare hands. They're going to have issues with orthostatics, so make sure you tell them to call for help when they want to get out of bed or walk to the bathroom if that's a possibility. Otherwise, they're still going to be on bed rest. And hopefully we're going to administer this to the client while they're sitting down, because if they're not, they could pass out. We want to take those patches that are going to indicate to us the measurement of the transdermal nitro. Make sure it's on a hairless area of the skin, and we're rotating sites. We talked about removing the old patches. And then we want them to be medication free between 10 and 12 hours. So it just happens that it's usually in the daytime. So, 9 to 9, or however pharmacy has put it in, is every 12 hours. We can do a continuous infusion of sodium nitroprusside, the same thing that we talked about for our inotropes and vasopressors for our hypertensive crisis. Anytime that they're on these medications, make sure that they are provided with continuous cardiac and blood pressure monitoring. We need to evaluate the effectiveness of that medication. So changes in our ECG, I do see down here in lead 2, so we're going to go all the way to the bottom, that I have highlighted that isometric line, and that I do see some ST elevation through here. Right? It's harder to figure out because your QRSs are going this way. Luckily, you're going to have a 12 lead that interprets what is happening in whatever area of the heart. So again, remember, I don't expect you guys to understand the difference between your lateral and anterior and posterior and what all these leads mean. That's for the doctors, but it does give us a good clue that I do need to perform some immediate interventions when I do see changes in this ST segments. And here I got T-wave inversion. Some of the side effects of our nitrates, the biggest one is going to be a headache. And if they complain of headache, you're going to give them Tylenol, acetaminophen. Changes in blood pressure, changes in LOC, dizziness because of the drops in blood pressure, flushing because of the drops in blood pressure. They may become less sensitive to it over time. We may need to adjust their doses, but again, that's probably going to be more of an outpatient thing. Our evaluations remain the same. I don't want you to have chest pain. Beta blockers we've talked about already. We know that they decrease myocardial O2 demand. We're going to use them to control stable angina. They end in LOL, but just watch for the 4 B's of beta blockers: your bradycardia, your blood glucose, bronchospasms, and blood pressure. Calcium channel blockers, again, to slow down heart rate, slow down electricity. We are used in Prinzmetal/variant angina, your Ipines. Usually it's your nicardipine or your nifedipine. You can use amlodipine if it's a blood pressure issue as well. We know that they cause hypotension. Anything that slows down electricity can cause an AV block. It can have an effect on your heart rate, headache, dizziness. I like the calcium channel blockers ask for help, so headache, prolonged PRI or elongated PRI, low heart rate, and low blood pressure. ACEs, we've talked about them as far as helping prevent remodeling or thrombolytic.